Hello, everyone. We're going to get started with our webinar. So my name is Ryan Adam. I'm the Director for the Health and Community Services team at Public Services Health and Safety Association. On behalf of Catherine Brookman, the Associate Director of Knowledge Transfer and Exchange, and Dr. Jack Callahan, Director for the Center of Research Expertise for the Prevention of Musculoskeletal Disorders, or CRE-MSD, and PSHSA, we would like to thank you for joining us for this free webinar on apps for back care. I would like to thank the Ministry of Labor for funding they provide, which supports the delivery of these webinars, and to our presenters to provide their expertise. This webinar is part of the Client Patient Handling Community Practice, and we encourage you to let your colleagues know about these events. The format for this webinar is as follows. The presentation will be given, after which we will have 10 to 15 minutes for questions. We ask that you type your questions into the chat box, and I will relay the questions to our presenters. Should you have a pressing question that cannot wait until the end of the presentation, please type this into the chat box and we will do our best to address this right away. The recording of this presentation, the presentation slides, resources, and any Q&As not addressed today will be available on the CRE-MSD website under the Communities of Practice section in the near future. Immediately following today's presentation, you will receive an evaluation, which we encourage you to complete to assist us in the future delivery of planning our webinars. Now, it is my pleasure to introduce you to our presenters, Dr. Tilak Dutta and Dr. Mike Holmes. Dr. Dutta is a scientist at the Toronto Rehabilitation Institute and the University Health Network and leads the Home and Community team. He completed his PhD in mechanical engineering in 2012 at the University of Toronto, focused on preventing back injuries in caregivers, and received funding from WSIB to produce a set of videos for caregivers to update their training and current understanding of what causes back injury. He's listed as an inventor on several patents, including the sling servant. Dr. Holmes is an assistant professor in the Department of Kinesiology at Brock University, where he holds a Canada Research Chair in Neuromuscular Mechanics and Ergonomics. Mike completed his undergraduate and master's degree at Memorial University, a PhD from McMaster University, and he was a postdoctoral fellow at the University of Waterloo. He spent 4 years at the University of Ontario Institute for Technology before joining Brock University in 2016. The Holmes Lab integrates biomechanics, neurophysiology, and robotics to better understand muscle recruitment, fatigue, and injury.
Okay, I guess it's Tilak here. I guess I'll get started. Thanks for that introduction, Ryan, and thanks to Bettina and Catherine and Jack for inviting us here to give this talk. Here's what we're going to be talking about today. 2 apps that we've been working on, one called SafeBack, one called PostureCoach. I'm going to introduce both apps and give talk a little bit about what motivated the development of them, and then Mike is going to go into a bit more of an in-depth analysis of a study he did with the first version of PostureCoach. I think the key message here for everybody who's joining us is to mention that these are prototypes. SafeBack is a little bit more finished than PostureCoach at this stage, but both of them are a bit clunky, and they're very much works in progress, and we'll talk more about kind of the issues around them right now. The goal is really to introduce you to these products, even though they're not fully ready for prime time, but to give you an idea of what we're working towards so that they, when they do come out in the next little while, you can make full use of them. So let me start with the big picture. The big picture is finding ways to support older adults as they age. We know that the caregiving tasks associated with providing care for older adults is a high risk, puts people at high risk of back injury, whether it's in the home environment or in a hospital or nursing home environment. The people that do some of the lifting and transferring and bathing, dressing tasks, all those things are at high risk of injury, and we've been trying for a long time to sort out why, how we can change that situation. so Emily King was a PhD student on our team who did a biomechanical analysis of a lot of these tasks in a simulated home environment, and you can see in these pictures we've got a real personal support worker and a patient actor who's being guided through a number of bathing and toileting activities, and you can see the kind of the extreme postures and heavy loads that are involved in a lot of these tasks. So it's really no surprise if you look at the sort of tasks that these workers are involved with that we see high rates of injuries. This is a little bit of data from the home care field for the personal support workers that we do most of our work with. About a third of them will say that they are suffering from an injury at any given time. Most of those injuries are in the low back, are to the low back. And as I said, home care is kind of a question mark. We suspect that the injury rates in this field are higher than some of the other healthcare fields or types of workers that are in hospitals and nursing homes, but certainly all of the healthcare related workers are at high risk compared to some of the other workforces, other industries. That's not to say that the apps that we're talking about today are targeted solely at healthcare. They could very well be useful in some other industries where, my understanding is that back injuries are either the number one or number two, injury type in a wide range of industries. And so it's probably something that could be adapted for any workplace where back injuries are an issue. You'll see in a minute that some of the tasks that we've been looking at are focused typically on healthcare, and for a couple of reasons, and I'll get into that in just a second. So I thought this would be a good time to ask a couple of questions to get a sense of what back injury training looks like in your organization. So here's the first question, and I'm going to ask Bettina to put up the first poll question. Does your organization provide back injury prevention training to workers? Let's see if that comes up. Oh, maybe we're having trouble with the poll questions. So I'll continue on, and if I see them come up, we can come back to those questions. I was going to just quickly ask, does your organization provide back injury prevention training to workers? How often is that training delivered? Is it a one-time thing, or is it something that people get refreshed on any sort of regular basis? And where does that training get delivered? And I'll tell you what I've experienced in my work with personal support workers. It's been in classroom environments like this. So these personal support workers will gather will sit and listen to a series of slides, PowerPoint slides, and then perhaps have some time near the end where they actually go through a series of patient lifting sort of simulations where they pair up or work in groups and kind of act out some scenarios, transferring lifting scenarios that they just sort of try to simulate with whatever furniture is in the room. And I think one of the obvious challenges here is that these tasks don't necessarily reflect the real world scenarios very well, and even some of the work that Emily King did in her PhD, this is a simulated home environment. It, in fact, doesn't necessarily reflect what the real world looks like, right? We have a lot of unpredictability in this type of home care work, and there's quite a bit of data out there that shows that this sort of back injury prevention, body mechanics training that's typically delivered in this classroom format doesn't necessarily translate very well to the real world. We don't see changes in behavior typically. We don't see a drop in injury rates. And I think a big piece of that might be that we're not doing the training in the real world. And so we have one of the apps that we're going to talk about, PostureCoach, allows us to provide some of this training in the But as a whole, let me just try to encompass what I think are the key three messages that we probably want to pass on to if they're healthcare workers or any other kind of workers, if we're trying to get them, if we want people to understand the risks of that back injury pose to them, here are the three kind of messages that I think we need to get across. The first is that back injuries are due to a buildup of damage, cumulative damage over many years of work over a long-term period. And just because you've done some type of work for a period of time and you haven't gotten an injury doesn't mean you're not going to get an injury. The second message is that you want to avoid bending. I should have put in brackets there, bending and reaching if you can. But if you have to bend, that there's a better way to bend, which is to stick your bum out, and I'll show you what I mean by that. And I think there's sort of different levels that we can start to dig into this. I think previous studies that have looked at, people that have looked at whether this sort of training is working, sometimes look for, they provide some sort of training and then they look for a change in injury rate. But I think there's a number of levels at which that we could try to probe this a little more carefully and more specifically to understand where things might be going wrong. First of all, do people understand, are the workers understanding the messages we're giving them? In my experience, when they're presented through PowerPoint, there are certainly cases where I've seen the message could have been made more intuitive, and so I think there's an evaluation that needs to happen in terms of how we're sending this message out, and I can show you some of the messaging that's worked for us as that first step. The second question then you can ask is, if they did understand a message, did it result in a change in behavior? And if not, why is that? And some people maybe will never be able to change their behavior the way you want them to because they have limited strength or limited flexibility for various reasons. And so we have to sort of deal with that challenge. Like, does the person understand what they need to be able to do? Does we actually see them changing the way they're doing their jobs? And then do we actually see a change in injury rate? And I think if we don't break this apart a little bit, it'll be hard. If we just look at injury rates all the time, it's hard to understand why something's going wrong in some of these training programs. But with that in mind, I think, in terms of making those three messages that I put up there in red more intuitive, the first one, I think, the fact that you need that these injuries are due to cumulative exposure or it's not the result of any one activity, I think that one gets across fairly clearly. People understand that message. However, the need to avoid bending, I don't think people understand very clearly, and we found that showing it this way or trying to get the message across using some images like this can help. And this is, so it's sort of like describing the bending when you're bending, demonstrating that it sort of is like your body acting like a lopsided teeter-totter. And even though the thing you're lifting might be relatively, might not be that heavy, the loads generated on your spine can be very large. And that's because of the way our body balances loads or generate forces in our spine when we're lifting and moving things. What happens when you're bent over is the weight of your upper body mass and the weight of what you're lifting has to be balanced over this tiny little moment arm in our back that is where our erector spinae muscles attach and pull down to balance all that load. And because it's working on such a small moment arm, we end up with, you can have a huge force there. And the sum of all three of those forces is what our spine feels. And that is why even a small lifting something that's relatively lightweight can result in a big force. And it's also why small changes in posture can make a big difference in the load that we feel. So this is how we present that kind of in the PowerPoint portion of a training session. And then we developed this app called SafeBack to try to make it a little bit more intuitive to allow people to play around with this idea a bit further. So this app allows you to take a photo of someone in a certain posture, and you pose this 3D skeleton to match the picture. And and then the app basically tells you whether the load on their spine is safe or unsafe. And you can kind of play around with the posture of the stick person to show if you straighten them out a little bit more, suddenly it goes from being unsafe to a safe posture based on the NIOSH limit, a safe limit for how much force the spine can support. And so the idea here is this app could be used in part of one of these training sessions to try to get that message, to try to get people to intuitively understand that message a little more clearly. So that product, that app, SafeBack, is available for free on the Google Play Store. You can download it and play around with it. We've evaluated it with quite a few PSWs and quite a few sessions at St. Elizabeth Healthcare as one of our partners, and they've sort of pilot tested this quite extensively with their workers, and we found that it is clunky. It's not always the easiest thing to get everyone working with, but once people understand how to use it, it does, I think, help people understand the concept. So that's the first idea. Or I guess it was message 2, right? Avoid bending if you can. But in healthcare especially, bending is sometimes necessary. And so, for instance, if you're washing someone's feet, a personal support worker cannot avoid bending. So simply telling someone to avoid bending isn't necessarily a practical solution. This is where our kind of third message comes in, which is if you have to bend, there's a better way to bend, which is the key being that you want to maintain the neutral curve in your spine. And so the picture under the green check mark, you can see we have this person here bending with what we call a hip hinge, so bending more from the hip rather than flexing the spine. If you can bend this way, what you do is you keep the facet joints in your spine and locked together, and it creates a much more solid unit. It makes your spine one solid unit that can withstand a lot higher forces without the risk of damage. Compared to if you flex your spine, what happens is your facet joints separate, you end up concentrating loads on the intervertebral discs, and you just are at higher risk of some sort of injury. So we want to teach people to try to think about bending this way instead of this way. So it's one thing, again, to tell someone to do that, but it's, again, in the field when you're seeing patient after patient, or client after client, and you're tired and you have to, you're moving on to your next client. These body mechanics kinds of lessons, messages, don't always stay front of mind. And so we developed PostureCoach to try to underscore or to try to really prompt the worker, the healthcare worker, at the right time, to give them a little reminder to say, hey, check your posture. Could you be doing this in a safer way based on the hip hinge that we know we want to do? And so this version 1 of PostureCoach was really based on 2 small sensors. They're little sensors that have accelerometers in them that can detect the angle that you're bending at. So these 2 sensors talk to each other and to this phone. So the app was running on the phone, communicating by Bluetooth to these 2 sensors, and based on the information it gets, it can give you a little warning or a beep if you bend flexing your spine rather than bend keeping your spine straight. So this is just to give you an idea of how that works. What you see on the computer screen there to the left of the screen demonstrates how this, the data that would be going to the phone, in this case, is going to the computer screen. And you can see that exclamation mark defines defines when the system would be giving the healthcare worker a little prompt, a vibration or whatever, to remind them to think about their posture in that moment and maybe straighten out. So we tested this thing, a quick and dirty study with 18 people, and where we had them, I'll just play that one more time here. So we had these 18 participants place a sling under a patient actor. We had them lift them out of a bed into a wheelchair. We had them roll the wheelchair into a bathroom and help take down the person's pants. So that activity, all those activities, what we did is we looked at how much flexion they had in their spine during those activities. And for instance, one of the participants, this is the kind of data we get. So the blue bars show the baseline for this participant, which means when they didn't have any feedback from the system, we were only using the PostureCoach system to track their movements. What you see is they spent more time in higher angles, higher and more flexion. They spent more time with higher flexion compared to the red bars, where you see the participants, when they did have the feedback, spent less time at higher flexion angles. What's really interesting is when we turn the feedback off, the green bars, it seems like they spent even less time in those flexed angles. And so of our 18 participants, some of them had no experience, others were sort of student clinicians, occupational therapists, physiotherapists, and 6 of them were people with lots of experience in patient care. One of the things we noticed was some of the people with the most experience didn't benefit too much from the device, from having this system, because they were already avoiding too much flexion, and so there was not much benefit. But overall, we see the biggest benefits to kind of what we call our novice group, or our students who didn't have that much experience. We can see that we dropped the amount of time we spent at high angles by using this feedback system. We moved on to build version 2 of this system because we noticed 2 pretty big issues with the first version. Having it be an app actually had one, hooking up these Bluetooth sensors, getting them to communicate with the phone took a lot of time, and the issue was that the sensors that we used themselves, they were quite inaccurate at actually gauging the angles that we needed to, and so it would result in a lot of false activations. So version 2 of this system uses much higher accuracy sensors. For now, we've gone with a wired design, but the goal is to make it extra simple to use. Mohammed is going to be testing this system out. It's a one-touch. You turn it on, and it starts to give you feedback. This sensor goes on your upper back. This one goes on your lower back. Together, these feed data to this microcontroller, and it gives you a vibration if you bend the wrong way. This just gives you a sense of how much bigger errors we had with PostureCoach version 1 than version 2. I know Mike Holmes is going to talk in more detail about his evaluation of version 1, but what you see here is our gold standard Vicon system in the blue. You can see how close our PostureCoach version 2, how closely we can follow the bending angles now with PostureCoach version 2 than we could with version 1. Version 1 was causing all sorts of false activations that really would have made the system completely unusable in the field. And then the big question that we have to answer here is what our next master student, Megan Camachi, is going to do. She is going to determine how often this device needs to be worn to see a long-term change in behavior. So how, can you wear it? Do you need to wear it all the time, or can you wear it for a week or for a few hours a week and see and maintain some change of behavior where you develop a muscle memory? So that's the real question we have to answer in order to do this, in order to get the product out of and make sure it's useful. So thanks for listening. That's my email address if you want to ask me any questions, and I'll turn it over to Mike Holmes for the second part of our presentation today. And I'm told that there's going to be a slight delay. I'm going to stop sharing my screen, and I'm told there's going to be a slight delay in getting the next presentation put up. So we'll just wait for that.
Okay, I think we're all set up here. Hi, everyone. Thanks for joining us today. I think that transition went a little smoother than we maybe had planned, so thanks to Bettina and Ryan for handling that. Um, so Tilak just gave a great overview of some of his team's work on app development for healthcare. Um, and that's a great segue for me because we collaborated with Tilak and he graciously let us use their posture coaching system. And really, that's what I'm going to talk about today. We evaluated Posture Coach during patient handling transfers in a student nurse population. I apologize if the text at the top there, the text box on my slides didn't look like that when I sent them. But so given that Tilak just covered some of this in a lot of detail, I'll try not to be redundant, and we'll briefly just introduce the topic here. Um, about 37% of Canadian nurses experience pain that's serious enough to affect their normal daily activities. And there's a lot of work that highlights the fact that patient handling is linked to the high incidence of low back pain in nurses. Um, risk factor, there are other risk factors as well, things like low staffing ratios and other problems that can lead to levels of fatigue, tight spaces, bed heights, patient and nurse anthropometrics, and so on. If we could give just a bit of a historical perspective for a second, um, we can go back probably even further than this, but in this case, this is a work from Gagnon and a group out of Quebec back in '87. They started to quantify spine loads during patient transfers. And as we move along, more and more people started to investigate this. And Bill Maris and his group in Ohio have spent a lot of time working on this. They've done comprehensive analysis of low back injury risk for all sorts of different patient transfers with different techniques. Moving on, a little bit more recent, in 2001, for instance, Richard Wells, who we're all familiar with from CRE-MSD, was a part of a group that started to evaluate peak as well as cumulative spine loads during patient handling tasks. A little bit of a shameless plug. In 2010, I was a part of some work where we evaluated long-term care nurses in the field and recorded their trunk motion throughout an entire shift and did some biomechanical modeling to estimate spine loads in that population. And sort of following the same trend of quantifying these spine loads, there's also been a lot of work simultaneously happening in terms of what are the effects, what are the spine loads during different interventions. And so there's been a lot of work in particular around mechanical lift devices. So the take-home message to a lot of this is that there are high spine loads during patient handling. That's quite clear. Bill Maris and his group have even suggested that it's almost going to be impossible to redesign or change a nurse or a caregiver's task. They're so physically demanding that there's been numerous intervention strategies that have been implemented. Education and training is a big one. That ranges from some more simplistic educational training programs, but also to very complex things around back education and back school programs. There's been a lot of work around equipment evaluation and design, especially mechanical lifts. There's been a lot of work around redesigning environments, making sure that policies and procedures have been reviewed, making sure that inspections are done at the correct times to see if people are enforcing their lift guidelines and policies. And there's been work around feedback during lifting. Despite these approaches, though, injury rates remain high in the profession. So carrying on with that feedback component for a second, which ties into what Tilak was just talking about, our approach was to try and use feedback for motor learning. And if we draw from the motor learning and motor control literature for a second to think about what the optimal ways are to accomplish the best type of feedback, we want to try to come up with an intervention that allows for permanent improvement or retention of somebody's skills. And we can tackle this a number of different ways. For instance, there's task intrinsic feedback, which include things like visual and auditory feedback. And there's also augmented feedback, where we can give people knowledge of their performance, which could be kinematic based, for instance. We could tell them in real time how they're performing, and that's sort of what the PostureCoach system focuses on. And we can also give them knowledge of results. So after they perform the task, we can give them feedback, maybe through a presentation or a video of how they performed. And really our approach tackled we came up with a combined approach to implement all three of these approaches. So in terms of feedback, there's been a little bit of work done in the area, but not much. Lavender did a study in 2000. This wasn't on a nursing population, but they performed feedback and coaching during a lifting task. And they found that side bending moments were reduced the most, and they only found marginal reductions in twisting and forward bending with their intervention. A little more recently, Belbeck and colleagues, this is from Clark Dickerson's group at Waterloo, they performed 5 different patient handling tasks and had a feedback session where there was a presentation on safe lifting practices given as the intervention, and they were able to show reductions in participants' ratings of perceived exertion for both the shoulder and low back following the training. In terms of the next steps, though, we've noticed that there tend to be gaps in the training approaches between student nurses and staff nurses. And there's also differences between academic and clinical environments in terms of how the training is provided. Experienced nurses may develop lifting techniques over time. That might be a good thing, and sometimes that might be a bad thing. And because of that, our focus has really been that we think nursing students should be the focus moving forward. So the purpose of our work was to explore the use of feedback or posture coaching to improve patient handling techniques in a student nurse population. So in terms of the methods for this work, we recruited 10 female nursing participants. They roughly were about halfway into a 4-year nursing program. And we tracked their trunk motion and kinematics with 2 approaches, 2 methods. We used the accelerometer-based sensors that Tilak just described, so we used the PostureCoach system. And then overlaid on top of the PostureCoach system, we had rigid bodies that would allow us to track trunk motion using motion capture cameras, so our laboratory gold standard, so to speak. So the PostureCoach system, as you just saw, are accelerometer-based sensors that would stream trunk angle data in real time to an Android smartphone. And within the application of the smartphone, you can set thresholds for which you want the sensors to vibrate or provide some sort of auditory feedback to the participant. I'll talk more about what our thresholds were in just a second. And so we also, like I just said, we also use motion capture cameras to track 3D kinematics using a Northern Digital motion capture system. So our participants performed 3 different patient transfers. We had a standardized mock patient that was consistent across all trials. So in task 1, our participants had to perform a sling under task where they would roll the patient to their side, place a sling underneath, and roll them back. A bed to chair task, which was a standard bed to chair task where the participant would begin in a lying position, very similar to the video that Tilak just showed. The nurse would have to sit the participant up on the edge of the bed. We would have a wheelchair positioned at the location that they desired with the wheels locked, and then they would transfer the patient from the bed to the wheelchair. And then finally, task 3 was a repositioning task with the help of a assistant. The nurse would reposition the patient and slide them up the bed. Our data collection timeline looked like this. We had a series of pre-feedback trials, a set of feedback trials, and then we finished off the session with another collection of post-feedback trials. So during our pre-feedback session, there was rest given between each of the tasks. So the participants performed each of the 3 patient handling maneuvers, and there were 4 repetitions performed of those tasks. So 4 repetitions each. And in this case, the PostureCoach system was turned off, so there was no feedback. Then for the feedback trials, the participants performed the same 3 tasks. This time we increased the number of repetitions to 8, and the PostureCoach system was turned on. So there was this real-time feedback component given during each of the repetitions of the lifts. And in between, during repetitions, we had a research assistant that would provide cues as well. So there was a verbal component as well as the feedback from the PostureCoach. And then we had a post-feedback session where we essentially did the same approach that we did in our pre-feedback trials. So the PostureCoach system would have been turned off for these 4 repetitions of each task. So following the pre-trials, we had an ergonomics graduate student and personal trainer discuss what Tilak just went over in terms of proper lifting mechanics. So we used similar images to what Tilak just showed you guys. And we dug into the literature a little bit to make a decision about what our PostureCoach threshold would be for trunk flexion. And in this case, we made a decision as a starting point to go with 45 degrees of trunk flexion. So in this case, when participants would flex their spine or their trunk greater than 45 degrees, the PostureCoach system would provide feedback to them. And then, like I said, the research assistant also provided verbal cues, things like keeping the patient close, straightening the back, using their legs, and the typical cues that we would often see in many back prevention programs. So trunk angles were calculated as the thorax relative to the pelvis, because we had sensors on the thorax and also located on the pelvis. We could calculate from that trunk velocity and acceleration, and we averaged our pre-trials and compared all of those statistically to the average of our post-trials. In terms of the results here, first of all, there'll be a couple of graphs to come up here in a second that are all set up the same way. So we have blue bars representing our pre-feedback trials and orange bars representing our post-feedback trials. Along the bottom, we have our different patient handling tasks, so the sling, bed to chair, and adjust. And in this case, we're showing the time to complete each of the tasks. And we found that the largest decrease was found for the bed to chair task of about a 6-second reduction from our pre to post trials. There were some reductions in the other maneuvers, however, they weren't significant. And we instructed our participants to perform the task as they normally would, as they saw fit. So these times are not, I would caution and say that these aren't necessarily times that we would expect to see in the workplace, but we did notice that there were a significant decrease from pre to post for the bed to chair task in terms of the overall completion time. In terms of trunk flexion, so again, the graph is set up the same way, and instead of time to complete the task on the side here, now we have peak trunk flexion in degrees. And we found that there was the largest decrease in, again, our bed to chair task. Roughly an 8-degree reduction in trunk flexion. There were some reductions in our other tasks as well, but again, they weren't significant. And you'll start to see as I quickly go through some of the rest of the slides here for the results, that this is the trend that we tended to see. What we would classify as the more complex task, being the bed to chair task. This was the one that seemed to be affected the most by our feedback intervention. trunk lateral bend. In this case, the graphs are set up the same way, but we have at the top trunk lateral bend to the right, and on the bottom trunk lateral bend to the left. We again found significant differences for the bed to chair task, and there were also some small differences for the sling task in this case. In terms of task rotation, this was some of our largest reductions. We found from pre to post, we found that the bed to chair task had a reduction of almost 9.5 degrees of trunk rotation, in particular to the left. And there were significant differences as well for trunk rotation to the right. To simplify the rest of the data a little bit, I've created a table here. So to present the trunk velocity, in this case, we have all the trunk velocity rotations across the top. So we have flexion extension, lateral bending to the right and left, and rotation to the right or left, or clockwise, counterclockwise. In this case, task 2 is our bed to chair task, and our stars there, our asterisk highlights that there was a significant pre to post difference in trunk velocity. And you can see that it was a reduction in trunk velocity across all the rotations for the bed to chair task. And the same thing for trunk acceleration. And we found, again, for the bed to chair task, significant reductions pre to post for all trunk acceleration rotations. So with that in mind, I think we were able to show that feedback during patient handling tasks can have a positive effect on lifting behaviors. Using the PostureCoach system, we did a very modest single feedback intervention session of only 8 repetitions, and we showed that we were able to reduce trunk angles, velocity, and accelerations in our student nurse population. The largest reductions were found in the bed to chair condition, the trunk flexion, and about a 9.5 degree reduction in trunk velocity. I think it's important to remind people as we start to think about this work, there's not necessarily an optimal lifting technique that universally fits all people. So with that in mind, though, we found that there were 8 to 10 degree changes in trunk posture, in particular for trunk flexion and rotation. And if we look at some of the cumulative spine loading literature, we know that posture greatly influences cumulative spine loading. So I would think that these changes that we saw, even though they may be minimal, they do suggest a more upright and neutral posture, which could aid in the reduction of cumulative spine loads over time. Our peak velocity data and acceleration data, to that matter, showed significant decreases in post-feedback sessions for all our measures. And if we look back at some of the classic work by Maris, they were able to classify trunk velocities and accelerations as low, medium, and high risk for the development of injury. And our peak trunk rotation velocity pre-feedback would have been classified as a high-risk category. And we were able to get that down to the medium risk category with our post-feedback trials, in particular for the bed to chair task. The intervention decreased trunk velocity and acceleration, yet if you remember back to the first graph in the results slides, the time to complete the task was also reduced. So I think that's interesting because it suggests that a more efficient movement strategy may have been used following feedback. And our participants, I think it's important to note that they were comfortable with patient handling. So they were roughly halfway through a 4-year nursing program, so they have had some placements and some experience to date. I think that helps support our work because it shows that the results are likely a consequence of the intervention itself and the feedback, as opposed to it being purely a learning effect. So to finish things up here, because I know we want to have some time for questions, the biomechanical evaluations and lift techniques can certainly be effective for improving movement strategies, but I think we also need to think, as Tilak started our presentation today, with the big picture. And the big picture in some of these discussions certainly revolve around factors affecting compliance with patient handling programs. Even with mandatory policies, student nurses, I think, need a proper lift culture and role models within their organization. So there really needs to be a top-down organizational approach that emphasizes safety and culture. And hopefully the use of such apps like PostureCoach can be used to help improve the training that's already in place, so that hopefully, which is going to be some follow-up work that we're going to do, we can start to evaluate long-term retention of those feedback sessions. So with that, I just want to thank everyone again for tuning in today. Special thanks to Tilak and his team for offering up the PostureCoach collaboration. And this work is hot off the press. It should be published very soon. So if anyone's interested in reading more about what I just presented, it should be in a recent issue coming up on transactions on occupational ergonomics and human factors. Thank you.
Thank you very much to Dr. Dutta and Dr. Holmes for your presentation. We do have about 10 minutes left. If anyone has any questions, if you can please type them into the chat box, then we'll relay those questions to Dr. Dutta and Dr. Holmes. First question, will the slides be available? Bettina can confirm, but I believe they will be sent out right after this presentation to all the participants, and they will be posted on the CRE-MSD website as well. Question from Rhonda Lambert. How much would a feedback device cost per person?
Yeah, I can take that one. It's Tilak here. We don't know yet. It really depends on what volumes we can produce them in. The current prototypes are rather expensive, in the $300 to $400 range, but that's a prototype, and once you get into larger numbers of production, we can bring that price down, but it's really hard to say till we haven't done that math yet and worked with a manufacturer.
Let's see, there's a few people typing, so we'll see if there are any more questions come in. Question that just came in. Did the participants provide comments on the feedback units, and what were they?
Yeah, on our testing, as I sort of mentioned, I alluded to a little bit, the annoyance factor was high with version 1 because we saw a lot of false, even when people weren't bending, they would get vibrations and beeps and things. And so that was, that's clearly going to be, a no-go for that product if it does that. So that's the reason we decided to kind of halt work with version 1 and switch quickly to version 2 with a more accurate sensor. We have yet to get to the point where we've tested it with real clinicians or PSWs or nurses, so we don't have any great feedback. What I can tell you wearing it myself is that it's that we've gotten around that particular problem. I'm sure Mike has other comments from his.
Yeah, we found, so we definitely noticed the problems that Tilak just mentioned. We got around some of those a little bit. If you notice some of my pictures, there was some redesigning of the harness and lots of tape used to make sure that the accelerometers were rigidly held in place. And with some due diligence, we did improve how accurately they were providing the feedback in terms of the threshold that we set. And in terms of what the participants' comments were, we actually found that the students they were in the lab individually, obviously, but they got really almost competitive. They were very much like, if that thing vibrated and buzzed on them, they were adamant that the next time they were going to try their best not to do it. So they really, I think, strived on that type of feedback versus most of the work that's been done in the past has really been education around showing them pictures and presentations and videos of what's been done. But I really think that getting that live real-time feedback is something that could trigger long-term changes for them.
We do have another question asking how an organization would be able to participate in a trial of these devices as it continues to be developed so that they can obtain more accurate feedback from real life scenarios.
Oh, Danielle, yeah. If you want to be a part of our testing, we're always looking for people who want to test, who would welcome us to test this in their workplaces. So I'll type my email address in here, and just you or anyone else who wants to get in touch can do that. Yeah, and I'll get you, and we'll talk. Yeah, let's get you involved.
Great. And based on some of the comments that were made, could the feedback units become a scoring device?
You mean would it be a way of, could at the end of the day, could you look back at the data and say how well you did that particular day? Yeah, we could certainly, you could do that. I guess there's a positive and negative to that. Like, would an employer negatively, could an employer use that information in some negative way? Yeah, it's possible. So I think there might be some ethical issues around that and preference issues around that that we would have to dig into. Right now, the system, the way we're thinking about designing the next version is that it wouldn't collect any data. It would simply give you feedback in real time, to try to make it as simple and as cheap and simple as we can possibly make the system. But there could be, you're right, there could be a benefit to somehow giving today you scored a whatever 8 out of 10, and tomorrow you can strive for a 9 out of 10 in terms of posture control. I don't know. Yeah, it's an interesting thought.
Then another question about participating in potential studies. Are you only looking for data on nursing populations, or can any organization participate?
Yeah, Tina, thanks for your question. I'm really excited to test this with any work group that thinks it might be beneficial. And it could just be again a quick and dirty test to put it on a couple of your workers and get their feedback. And so I'm sure we're going to find places where the type of feedback the type of bending we're trying to encourage isn't even necessary. In places where you can work more upright and you don't need to hip hinge, it might not be appropriate for those workplaces, but it's really hard to say. It would be great to test with any workforce. Tina, what workforce what type of industry are you thinking of? While she's typing, Rhonda, tell me if I answered your question. Was that what you were getting at in terms of a scoring device? Rehab facility, yeah. Yeah. I think we should talk. So you have my email address there. Please send me a note, and we can chat.
Great. Thank you very much. And again, that brings us to around 1 o'clock, which will be the end of our time today with this webinar. So again, thank you to Dr. Dutta and Dr. Holmes for your time and presenting and sharing your information with us. And thank you to all the participants who joined us today.
Great. Thanks, Ryan. Thanks, everybody.
Thank you, everyone. Apologies for the internet connection.